In this video, I'll talk about Haglund's deformity, which is a lump behind the heel, specifically at the calcaneus. This deformity consists of a little extra bone and can cause pain due to rubbing against the shoe. Over time, the constant rubbing of the protrusion against the Achilles tendon can cause pain in the tendon itself, which can then also become chronically inflamed and can suffer from small partial tears. Diagnosis is very simple and always begins with a physical examination, during which the doctor must assess where you have pain, whether the Achilles tendon is enlarged or not, whether the tendon still has good strength, and, very importantly, whether there is also reduced elasticity in the calf muscles, which can cause Achilles tendon pain. Examinations always begin with an X-ray of the ankle, which should be taken while standing because it gives us a better idea of how the ankle bones are aligned with each other. Very often, the doctor will also request an MRI scan if there's a suspicion of Achilles tendon pain. Ultrasound is still a fairly common test, but I find it of little use, so I personally almost never request it. I would like to focus a little more on magnetic resonance imaging, MRI, which, as I said before, better describes the characteristics of the Achilles tendon, which can simply be swollen, as in this case, and as I highlighted with the red arrows, due to rubbing against the bony protrusion, i.e. Haglund's deformity, indicated by the yellow arrow. In this second case, you can see another patient with a more evident protrusion, in which the red arrows not only indicate the increased size of the tendon, which is evidently chronically inflamed, but also highlight a central pain that you can see from a slightly grayer halo compared to the surrounding Achilles tendon, which should normally appear black. In this third and final photograph, we see a real lesion inside the tendon, as indicated by the yellow lines that delimit the white area, i.e. the rupture zone. Having a Haglund's deformity doesn't automatically mean you'll have pain. If you experience painful symptoms, it's always a good idea to try a non-invasive treatment, such as changing your shoes, choose looser, softer ones, or applying silicone patches to the protruding bone to reduce rubbing against the shoe. You can also try physiotherapy, such as T-car therapy or shockwaves, generated by an electronic machine that releases localized energy. In the short video you see now, the shockwave treatment is done for plantar fasciitis and not for Haglund's deformity, but the concept of the treatment remains the same. A probe is applied to the area to be treated, and this probe releases the shockwaves. If conservative treatment does not work, then a surgical solution may actually be proposed. Minimally invasive or with a longer incision, about 10 or more centimeters, regardless of whether the operation is performed with the longest incision or with the minimally invasive technique, the anesthesia can be total, also called narcosis or spinal, i.e. with an injection made behind the back, which is not painful and is certainly much more effective than narcosis in adequately controlling pain in the hours following the operation. Sometimes a peripheral block is also associated, that is, anesthesia at the level of the thigh or calf to control the pain even better and for even longer over the following hours. What you see now is a popliteal block, that is, anesthesia administered by the anesthetist under ultrasound guidance to inject a minimal amount of anesthetic right near the nerve that is identified with the aid of ultrasound. The minimally invasive procedure is performed with the aid of a 4mm camera inserted through 2 or 3 small 5mm incisions in the skin. I won't go into this surgical technique in detail, but I'd like to emphasize that this type of surgery is indicated for cases of bony protrusion, but with a healthy Achilles tendon, meaning one that isn't significantly damaged and, above all, without calcifications or tears. At the end of this video, you'll find the link I encourage you to consult. In case of particularly damaged tendons, the recommended surgical intervention is the one with the longest surgical incision, which is made at the back of the heel. The incision also extends along the final portion of the Achilles tendon, which will be opened and cleaned. Surgery always begins by compressing the leg with an elastic tourniquet, used immediately before inflating a pneumatic tourniquet placed on the thigh. This is intended to prevent bleeding during surgery and will be deflated at the end of the procedure. Before starting the actual surgery, we identify the bony protrusion and the course of the Achilles tendon along which to place the surgical incision. In this case, I had to make a second incision above the main one as the calf muscles were very shortened, meaning they had little elasticity, so I had to lengthen them. This surgical procedure is not always necessary. Just below the skin incision, we find the Achilles tendon, which is cut along its entire thickness in a longitudinal direction. The tendon must therefore be detached, but only partially, from its insertion on the heel bone to allow complete visibility of the portion of excess bone that we need to remove. In this patient, the Achilles tendon is clearly suffering and swollen, also having an area of altered consistency due to the presence of calcification that was already clearly visible on the magnetic resonance, imaging, MRI, and which I had to remove. Now I use a saw to remove the protruding bone. In addition to the saw, we also need to use a series of chisels to gradually remove the excess bone, which is always more than one might expect. In fact, it's not uncommon for another cut to be made after the first bone cut to remove the bone that wasn't completely removed previously. To verify whether we've removed enough bone, the surgeon palpates the bone repeatedly, but we also need a more objective criterion, so we use a low-energy X-ray machine to demonstrate whether we've adequately removed the excess bone. After removing the excess bone, we need to reattach the Achilles tendon that we initially detached, albeit incompletely, to allow full body walking as soon as possible, and above all, to allow the tendon to heal in the most anatomical position possible and in the shortest time possible. What you see is probably the most widely used system on the market, which involves the creation of 4 tunnels in the bone, parallel to each other. Through these 4 tunnels, absorbable screws are inserted, to which a non-absorbable thread is connected, which is passed through the tendon and will allow the tendon to adhere firmly to the bone. The approximation of the Achilles tendon to the bone will therefore allow for good healing of these 2 anatomical structures. Once the tendon has been permanently anchored to the heel bone, we can use an absorbable suture, as you see, one that will dissolve on its own over the following weeks to close the cut in the Achilles tendon and reconstruct it as perfectly as possible. After surgery, we apply a long boot brace that is worn for 4 to 6 weeks and on which full weight bearing can begin only after the second week. While you have the brace, it will be advisable to have an injection with a very small needle of low molecular weight heparin, which serves to thin the blood and therefore serves to reduce the risk of deep vein thrombosis. Especially in the initial stages, it will be very important to use 2 crutches to try to walk without placing all your weight on the operated limb on the ground. As long as you keep the brace on, it's best not to drive, not only because your foot can't be used to operate the car pedals, but also because keeping your foot low, and this is a general rule, will increase the swelling, and therefore the pain may also increase. For at least a month, you should avoid doing any chores around the house, such as cleaning floors, ironing, or cooking. To maximize skin and tendon healing, it's very important to avoid smoking. Ideally, you should quit smoking a month before surgery. For the first 5 days after surgery, it is advisable to take painkillers regularly and then only take them as needed. The stitches I use to close the skin are generally absorbable and will therefore fall out on their own without having to be removed in the doctor's office. To reduce the risk of infection, it is absolutely forbidden to wet the wound. So if you have to shower, it is best to use waterproof bags that you can find at the pharmacy, even better if reinforced with kitchen cellophane that must be wrapped all around, starting from the toes up to the knee. Physiotherapy is started 2 or 3 weeks after surgery, but your surgeon will tell you when to start it. As with any surgery, there are risks. Although the percentage of satisfied patients is extremely high, it is essential to know from the outset that complete recovery can take more than 6 months. One of the risks, however well below 1%, is infection, for which, in addition to taking antibiotics, it may also be necessary to clean the wound in the operating room. Another low risk, even in this case, is deep vein thrombosis. As I mentioned earlier, for 6 weeks after surgery, you'll need a small injection in your abdomen or thigh to thin the blood, significantly reducing the risk of a blood clot forming in the operated leg, which could also cause a pulmonary embolism. There are oral anticoagulants on the market, but they're prohibited in my daily practice. I prefer to always use heparin anyway. The operated foot may remain swollen longer than expected, especially if you already have venous insufficiency. For this reason, your physiotherapist may also perform lymphatic drainage, helping to reduce post-operative swelling, which, however, could potentially persist for several months. The ankle may remain stiff, primarily due to the reduced elasticity of the calf muscles, resulting from post-operative immobility. This may improve with physical therapy, and especially with the stretching exercises recommended by your surgeon. Nerve damage is possible, although extremely rare. The nerves most at risk are the posterior tibial nerve and the sural nerve. The last risk I would like to list for you, which is also extremely rare, is the complete detachment of the Achilles tendon. As I showed you in the video, to remove the bony protrusion, we need to detach the Achilles tendon slightly from its insertion on the bone. To avoid the risk of the tendon detaching completely when you walk without a brace, we use the system with the anchors and sutures I showed you. Thank you.